screen, right?
Yes. Varsha, you are there in the meeting?
Ganesh must be there.
No, he told me that Varsha will be there today. Anybody?
But firstly, I think Mr. Ganesh spoke initially when the meeting was started.
Okay. So Ganesh, are you there?
No, ma'am, Ganesh is not there.
Okay. So Varsha, you are there. You will be sharing the.
Yes, ma'am. I will share.
Sorry, madam, I'm joining from a new device. Could you help me how to share my PPT here?
Varsha, please.
Yes.
So I can see the icon of share screen. Yeah.
Yes, sir, ma'am. Please click.
Yes. I have clicked it.
Select one window.
Window, yes. But I cannot see the PPT being appearing here.
मैम आपको वो फोल्डर में जाना पड़ेगा इसलिए वो.
Poonam, can you see your desktop?
Wait.
When you are sharing, can you see your desktop?
Yes, I can see the Zoom itself.
Go into the PowerPoint from there, and you must have opened your recent presentation, so you can start. Otherwise, you have to log out completely from Zoom, open your PPT, minimize your PPT, and then log in Zoom.
So I have already minimized my PPT, madam, here.
Yes, so from your
but I cannot see it, yeah. Wait.
Click the share button and then start PPT.
Yes, Poonam.
No, but PPT you cannot see, right? Because I cannot see my PPT here. I think I'll log out and I'll again minimize and join. Is that okay?
Yes.
Yes, you can do.
You can share your PPT to Varsha. Varsha will then.
No, madam can be made co-host as well, and then it will be easily shared. Just try that.
Co-host. Sujata, she is co-host.
But I'll just log out and again I'll join.
Dr. Poonam Ghorki is co-host, no?
No, ma'am. 1 minute.
So
yeah, that may be the reason why I'm not able to share.
Yes, ma'am. Abhi Poonam ma'am hai abhi co-host hai. Please, ma'am, please try.
Now
let me try. Yeah, now let me try.
Webinar.
No, not still. I think I'll log out and I'll have again join back.
Okay. So Poonam, meanwhile, we will start the introduction.
Sure, ma'am. Sure.
Yes. So Rajesh, please start.
Yes, ma'am. Good evening and welcome to Dr. Sunil Pandya sir, today's eminent speaker, and Dr. Poonam Ghorki ma'am, our GC from Society of Anesthesiologists, Pune. Today's chairperson, I would like to welcome Dr. Sunanda Gupta ma'am and Dr. Anjali Bhure madam, our past Vice President of IIT National. This is the third webinar from the SAMS this year, and we are going with the theme Safe Anesthesia Saves Life. Today's seminar is on ERAS, that is Enhanced Recovery After Anesthesia. We are dealing with two subjects, one from ERAS in obstetrics and second one is the basics of ERAS.
Thank you, Rajesh. So in short, I want to talk about the theme of our SAMS webinars. It is Safe Anesthesia Saves Lives. And safety is of very much importance. Safety is different for everybody, and actually enhanced recovery is such a concept. Now we tend to think that enhanced recovery only has to be done in very sick patients or for supra major surgeries or for corporate hospitals, big hospitals. But actually our experts today, from them we would like to learn that in our day-to-day practice as a private practitioner, in a nursing home practice also we can practice certain few components of enhanced recovery. So, what are those few things that we can still practice at our own private small nursing home also? So, let us see this. And now I welcome our chairpersons, Dr. Sunanda Gupta madam and Dr. Anjali Bhure madam, and I request Dr. Parna to introduce Dr. Sunanda Gupta.
Thank you, ma'am. Good evening, all. It's an honor to welcome Dr. Sunanda Gupta, ma'am, a renowned expert in the field of anesthesiology, particularly in obstetric anesthesia. As a professor emeritus at Gitanjali Medical College in Udaipur, ma'am brings a wealth of knowledge and experience to our webinar today. With an impressive academic background, including an MD, PhD, and fellowship programs at prestigious institutions, Gupta ma'am is a highly respected figure in the medical community. She holds important positions, and she's a founder president of Association of Obstetric Anesthesiologists. She's an executive member of Obstetric Anesthesia Society Asia Oceania. She is executive member working committee of Indian College of Anesthesiologists, member of editorial board of four peer review journals. Madam is a member of Obstetric Anesthesiologists Association UK. She has several publications and textbooks on obstetric anesthesia and basics of anesthesiology and resuscitation. She has 6 awards, 8 orations, 190 conferences to her credit. She was a guest faculty at many international conferences and a visiting professor at Birmingham Women's Hospital, Harvard University, Boston. Welcome, ma'am, from SAMS.
Thank you very much, Parna.
Thank you, sir.
Now I welcome, good evening, everybody. I welcome my big sister, not only my, all of us big sister, Dr. Anjali Bhure ma'am. She is affiliated to NKP Salve Institute of Medical Sciences, and she is working and practicing since last 33 years. Her area of interest is obstetric anesthesia and public awareness program. All of us know she was a vice president of ISA National. She had so many national and international publication with her. She was governing council member of ISA National, honorary secretary of West Zone of ISA, president of ISA NCB, and she is on Maharashtra State chapter of ISA advisory board member and organizing chairman of ISACON 2021 at Nagpur. She was awarded by ISA National, Maharashtra State, then IMA also, Nagpur branch, and she was awarded by NKP Salve Institute of Medical Sciences. And I know she is very calm and very helpful, so I call her a big sister. Welcome, Bhure ma'am.
Now I welcome our guest faculty, Dr. Pandya sir. Actually, Dr. Sunil Pandya sir does not need any introduction, and I have been listening to his lectures since past 20-25 years. He's a very, very busy practitioner, and he is at present heading the Prerana Anesthesia and Critical Care Group, and 2 big hospitals he's catering to. One is AIG Hospital Hyderabad and Fernandez Hospital Hyderabad. So we want to know, Panda sir, how you take care of such big, huge hospitals, and I mean, so many anesthetists are working under him, and his CV is very, very big. So if I actually read his CV, it will take around half an hour for that only. He has a huge 25-30 pages curriculum vitae. So, sir is the founder director of Prerana Group, and he has been the PhD guide and faculty, and he has multiple n number of publications to his credit, and he is associated with so many institutions. So, really, I am at a loss for introducing Dr. Sunil Panda sir in short. So with this very, very short, ultra short introduction, I welcome you sir, to SAM's webinars. Now I request Dr. Rajesh to introduce Dr. Poonam, and then Poonam, we will start with your lecture. I can see Poonam, you are able to share the screen.
I joined from the older device, yes.
Okay, okay.
Dr. Poonam Ghorki, ma'am, she is MD and DNB anesthesia, and presently she is working in a Dinanath Mangeshkar Hospital and Research Center at Pune. She was an ex-professor and she has received Best National IJ Reviewer Award in 2022. She has also received Lakshmi Kamath Award in 2021 and winner of essay competition in various conferences. Prajna Trophy for the best paper at the National Research Conference 2020. BMC nomination 2017 for the best research and publication. She has also ISA Appreciation Award by SAP 2016 to 2019 in 2023. She has also received G.S. Ambedkar Award and SMT Bhagirathi Award in 2007 for the academic excellence from the Mumbai University in MD examination. She has several publications in national and international journals and
Rajesh? Yeah, Poonam, you can start. I think there is some issue with
I
Rajesh.
think my slide is stuck. I'm not sure. This is the third slide that is going on. Anyway, good evening, everyone. I bring greetings from the Dinanath Mangeshkar Hospital and Research Center, Pune. At the outset, I would like to thank Anita Nehete madam and all the office bearers of SAM for having me today here for a very important topic on ERAS. So if you look into the historical aspects of ERAS, if we compare the then and now, ERAS was introduced somewhere around 1997 by the name of fast track surgery. So even I remember during my residency, especially in cardiac OT, we used to start the patient towards the end with an atracurium infusion. We used to shift the patients with the infusion to the ICU, and then the infusion used to be stopped after 6 hours, and then weaning and extubation. So that used to be a prolonged recovery. However, with the introduction of fast track surgery, somewhere around 2004 or 5, we used to discontinue this infusion, shift the patient to the ICU, wherein he used to be weaned off early and extubated early. So that was the eras of that time. But today we have an international society dedicated to eras altogether. Are my slides moving here? Yes. So this is a question by the patient that how long does it take to recover from any surgery? This question is the reason for existence of ERAS. So in my today's talk also, if I am going to outline my talk here, so we will be talking about what is ERAS. We will be discussing the facts related to ERAS and also demystifying certain myths. Of course, we will be talking about the basics of ERAS because that is what the topic given to me is. And lastly, we would be discussing how to implement ERAS in one's own practice. Wait, but why in the first place should we be talking about ERAS? Why ERAS? Whatever we have been following for so many years, why to change that practice and get introduced to this new idea of ERAS? So for this, let us take a hypothetical case. Now, this case is your patient who is for whom you are not going to be the anesthetist. The slides are not moving quickly. Yeah, for you, for whom you are not going to be the anesthetist, but this patient is related to you, maybe your kith or kin. So she is a 56 years old female with no comorbidities, and she is scheduled for abdominal surgery, say lap cholecystectomy or hysterectomy or any oncosurgery. She is scheduled at 9 a.m. in the morning and she is asked to start from 10 p.m. So that is almost 11 hours. And don't be surprised because most of the institute would have this protocol to keep the patient's NBM from 10 p.m. This mainly happens for two reasons. First of all, you fear that the patient may just eat something and not follow the NBM hours. And suppose if on your list one patient gets postponed, and if you want to prepone the next patient on the list, not being NBM should not be an obstacle. Otherwise, the resources would be wasted. So that are some reasons not justifying the NBM for 11 hours though. Then from surgical point of view, she was asked to take a mechanical bowel preparation in the form of enema in the night before surgery. As a relative, you go and meet her in the pre-operative period where she is very anxious and she's hungry because she's been starving for so long, and all the she can think is about the food thoughts and which are causing hunger pranks. But being an anesthetist, you convince her that no, this starvation is required for an optimum outcome and it is a prerequisite for this surgery. So being convinced, she gets wheeled inside the OT. Sorry. Slides are just not moving the way they should. Just wait. I'm so sorry. Okay. So she goes inside the OT where a conventional anesthesia management is done by the anesthetist who gives her propofol, fentanyl, muscle relaxant, ondansetron as a part of PONV prophylaxis. The anesthesia is maintained with air, oxygen, sevoflurane, and the anesthetist chooses to give midazolam as a pre-medication, may or may not give glycopyrrolate. The surgery lasts for around 2 hours. The patient is infused with 2 pints of RL. And to maintain the hemodynamic parameters, the anesthetist does give intraoperative boluses of opioids. The patient receives paracetamol, Dynapar, and for a rescue, tramadol is kept for postoperative pain. The surgeon infiltrates at the local site with a local anesthetic drug. Towards the end of the surgery, the patient is reversed and extubated. And you again go and meet this patient in the recovery. So in the post-operative period, the patient has no complaints of major pain. So the anesthetist has done a good job as far as the analgesia is concerned. But the patient is having post-operative nausea and vomiting, which is kind of incapacitating her. An RT was put for the surgery, which is left over there, and that is causing discomfort. And yes, the patient is now feeling very thirsty. Her throat is almost parched and she's famished. She just wants to know when she can eat. So, although the surgery was successful, uneventful, if you compare the quality of recovery score, that was not satisfactory. So, was there anything that was missed in this management, or is there anything that could have been done better? If we try and answer these questions, probably the transition from the traditional perioperative management to the ERAS protocol would be little easy. So, let us try and find out if there was anything missing or what did we miss talking about in this management. So, firstly, the thing called as pre-operative nutrition was completely missed out. We do not bother about the pre-operative nutrition in the perioperative management. We do discuss about the optimization. For example, in the PAC clinic, if the patient is having anemia or any other comorbid conditions, we try to optimize them. If suppose patient is having certain addictions, so we ask them to cease smoking or quit alcohol or whatever. So that optimization is being done, but we really do not take preoperative nutrition as a major concern in the perioperative management. Yes, and eminently antibiotic prophylaxis was dropped in this discussion. Antibiotic prophylaxis is very, very important. Antimicrobials have to be given to the patient in the perioperative period to prevent the surgical site infection. Now, the best time would be to give it just before the incision or maybe within half an hour before the patient is to be taken inside the OT. In fact, one should repeat the antibiotics if the surgery is prolonged to beyond 4 hours or if the blood loss is more than 1500 ml. So antibiotic prophylaxis is very, very important, and we as anesthetists should always look into the fact whether the patient has or not received the antibiotics. It is very easy for us to do that. Secondly, DVT prophylaxis. So as antibiotic prophylaxis is important, we also want the patient to be free of complications in the post-operative period. So DVT prophylaxis becomes very, very important. Simple applying of bandages or stockings to the lower limbs, bilateral lower limbs for prolonged surgery. If you have pneumatic pumps, they can be applied. The thing is they are reusable also. So economy also is concerned. Then you can reuse these stockinets for many patients and DVT prophylaxis can be implemented. We did not mention anything about post-operative starvation period. Of course, we do write at the end of the surgery when we write our notes, NBM for 6 hours. So this is like when you ask the surgeon how much time he's going to take to finish the surgery and he says 30 minutes, but you really do not know when the first minute of the 30 minutes is going to begin and then the surgery lasts for endlessly. Similarly, when you write NBM for 6 hours, it makes no sense. So in our institute, we have a practice to write NBM till 6 p.m., till 4 p.m., till 2 p.m. So the patient and the nursing staff exactly knows precisely when the patient can start consuming orally. So that order has to be very, very clear. Ambulation part was missing. When you meet the patients in the recovery, they ask when they can turn around, when they can sit. So these orders should be very clearly discussed with the nursing staff, and these also should be told to the ward as to when the patient can sit, which you have to facilitate as early as possible if you want to improve or enhance the recovery. So if this lecture was in an auditorium, I would have asked a poll as to how many patients, how many anesthetists really follow up the WHO safety checklist, which is a prerequisite by the NABH. If you are doing and following this checklist, it is very good practice to tick if antibiotic prophylaxis has been given, if the patient is eligible for DVT prophylaxis. So once you tick, you know, and it is kind of an assurance that the patient has received antibiotic preoperatively. Are there certain modifications that could have been done in the perioperative management that we discussed? So yes, the NBM hours, everybody would agree that 11 hours NBM is just too much, not at all desirable. What we are taught is 6 hours of NBM from solid foods. But with IRAS protocol, IRAS advises or advocates that the patient can drink clear fluid for 2 hours before the surgery. Now, this is something that will shatter our doctrine and teaching of the 6 hours NBM. But it is not only us, but even for the surgeons. Now, as far as the mechanical bowel preparation in the form of enema is concerned, IRAS protocol advises against mechanical bowel preparation. Now, whenever enema is given for oncosurgeries or abdominal surgeries or any kind of surgeries in the pelvis, the aim is that the gut becomes free of the feces, and so the bacterial contamination decreases, decreasing the overall risk of infection. So that is the rationale behind giving enema. However, with enema, there is associated electrolyte and metabolic disturbance that can happen. And also, when enema is given, the solid feces liquefies. So when there is anastomosis, there can be actual risk of anastomotic leak that can happen. So IRAS does not advise MBP to all the patients, especially for colonic surgeries. If it is right side surgery, it can be easily skipped. For left side surgery, you may still give MBP to the patients, but otherwise, for IRAS, MBP is not something which can be done for all the patients. So NBM from our side and MBP for the surgeon is something that we have to overcome the traditional teaching. IRAS does not let us give pre-medications because with sedation or preoperative glycopyrrolate, the post-operative recovery can be hampered. So if you give midazolam in the preoperative period, there have been numerous studies which show an increased risk of post-operative cognitive dysfunction. So any complication in the post-operative period naturally will delay the recovery. As per the IRAS protocol, an opioid sparing anesthesia should be provided to the patient. Now, few years ago, opioid free anesthesia, OFA, was in vogue. But OFA is not something that our nation really needs because we do not have many patients who are really addicted to opioids. So opioid sparing anesthesia is good enough for us. Now, why opioid sparing anesthesia? That is because the more opioids you give intraoperatively, the more delayed recovery the patient will have in the form of respiratory depression. There could be pruritus, there could be vomiting. You do not want all that just to provide analgesia. So analgesia, there are various other ways. You can give magnesium, you can give lignocaine infusion, you can give ketamine, and so many drugs can be given instead of opioids if analgesia is our only aim. Intraoperative fluid status. Now we have a practice or a habit of giving at least 1 pint to the patient no matter what the surgery is. Even if the patient is for IND, we would infuse him with 1 pint of RN. That is incorrect. Fluid should be very purposefully administered to the patient. There has been a trial called as the relief trial where they studied restrictive fluid administration versus liberal fluid administration. So when the surgery is a low risk surgery or a moderate surgery, one should give restricted fluid in the form that it should be very judicious. There should not be excessive fluid administration, especially when there is anastomosis. So if you give more fluid, this fluid is going to go into the interstitium. It is going to cause bowel edema, and the anastomosis will not be proper. Also, when they are giving flap surgeries, and if you give vasoconstrictors instead of fluids to increase the BP, it is not going to keep the flap viable. So a balance is needed between the fluids and the vasoactive drugs that you give to maintain stable hemodynamics. So a very judicious fluid administration is required. So if fluid requirement is not that much, you can follow something which is called as a zero balance fluid therapy. So 1 to 3 ml per ideal body weight kg per hour can be given. And if the surgery is major, for example, if it is a neurosurgery, you could follow the goal directed fluid therapy where you actually have to monitor the outcomes, for example, the cardiac output or the stroke volume, and then administer the fluid. So fluid has to be given very, very judiciously. That was missed out in this management. Temperature. Now, although temperature monitoring is one of the minimum monitoring standards by ASA, we do not really monitor the temperature in all the patients. Now, I put temperature monitoring to the patients for whom it is really required. If it is a major surgery or any surgery beyond 4 hours, the temperature monitoring would be put. Whether or not you monitor the temperature, you can always aim towards maintaining the normothermia. So warming mattresses, blankets, all these can be used whenever required. PONV prophylaxis. Now, everybody gives ondansetron to all our patients coming for surgery without categorizing them. So, of course, you have to give an antiemetic, but look at the APFIL score. If the patient is post-acute laparoscopic cholecystectomy, you can administer dexamethasone as an additional antiemetic agent to prevent the PONV. PONV will again delay the recovery of the patient. Drain and pipes. Now, whenever not necessary, do not put RT, do not insist on catheterization. Surgeons also should avoid putting drains unnecessarily because drains not only cause discomfort in the post-operative period, they also cause some pain. Now, for lap cholecystectomy, especially if you see, we put a Ryle's tube to decompress the stomach. But then why the stomach is full when the patient is starving? It is because during mask ventilation, inadvertently, some air enters into the stomach and it gets full. So be careful to vigilantly mask ventilate so that the stomach does not get full, so that there is no need to decompress. So if not required, do not put the RT. If at all it is required, you can put it orally. Why to put it nasally and increase the invasiveness? And once the surgery is done, while you're extubating, just take it out. So whatever you're putting in just for the sake of surgery, that should be out at the end of the surgery. So that is one of the modifications that can be done. Always include any kind of regional anesthesia technique to your anesthesia. That will also aid in providing opioid sparing anesthesia. So give epidural, give facial plane blocks, give tap blocks, give QLB, QACB. So all these blocks can be included. So once you practice all this, they will bring you more closer to the aims of ERAS, which exist right from the preoperative, intraoperative, and the postoperative period. So if you look all these missing or modifying agents, one is not related to the other. NBM is one thing, fluid status is one thing, temperature, drains. So all are different set which need to be intervened. So what is ERAS? ERAS is a heterogeneous set of interventions which you will modify as per the surgical need, right from pre, intra, and post-operative period. So I'm sure many of you would be already practicing ERAS without knowing it. If you as an anesthetist are looking into the antibiotic prophylaxis, if you as an anesthetist are ticking on the DVT prophylaxis, if you are judicious in your fluid management, then you're already practicing ERAS in one way or the other, which is a good thing. Before going into details of the ERAS, let us demystify the myths regarding ERAS. First is the full form. Early recovery is essential for ERAS, but the E is not early, it is enhanced. There are many other parameters other than early recovery. It is not necessary for you to discharge the patient on the same day. No. Patients posted for colorectal surgeries were the first ones to get ERAS. So a patient who stays admitted for 5 days is equally eligible for ERAS. Now tell me truly, whenever I say ERAS, don't you think about the carbohydrate load? So most of the anesthetists equate carbohydrate load to ERAS, meaning that they feel that carbohydrate load is only what ERAS is all about. Of course, carbohydrates and nutrition is an essential, important component of ERAS, but there are many other things other than carbohydrate drink which make ERAS. So that is a myth that you should be clear about. At least by the end of this talk, this is one thing I want every anesthetist to be clear about, that the drink is not equal to ERAS. Then other myths like, is ERAS only about GA? No, you can do ERAS even for spinal anesthesia. If you want to prevent post-operative urinary retention, that is POR, in a patient undergoing spinal anesthesia, because POR is going to delay the recovery. Do not add opioid. Restrict your fluids. So that way you will not have POR and you will be able to discharge the patient early. Can ERAS be practiced only in an institute? No. You can practice 80-90% of the ERAS even if you are a freelancer. Then only daycare surgeries? No. For example, I just mentioned that even colorectal surgeries where the patient stays in the hospital for 5 to 7 days, ERAS can still be followed. So if you consider all these parameters from pre, intra, and post-operative, and you compare the traditional protocol, so in counseling, yes, we take an informed consent, but do we evaluate the patient's nutrition in the preoperative period? No, not in the traditional protocol. We advise fasting, eventually landing up 11 to 12 hours of fasting period. We do give sedation, we do give pre-anesthetic. We do not really are concerned about the antibiotic prophylaxis, or the surgical approach is not very well discussed. We do not take into consideration the drains. Of course, pain, we are very much bothered as anesthetists. So all these things, if you compare it with the ERAS protocol, what you can see is the nutritional evaluation, a proper assessment is advised. Fasting hours is 6 hours for solid, but ERAS protocol advises to drink water for at least 2 hours before the surgery. One should discuss about the invasiveness of the surgery. As far as possible, the surgeon should do minimally invasive surgery. Antibiotic prophylaxis should be checked. So if you compare these two, fasting and the analgesic regimen, multimodal analgesia is something you can implement right from tomorrow. Now, why so much importance is given to the nutritional evaluation in ERAS? So the philosophy of ERAS is food is medicine, which is true. Preoperative nutrition is the cornerstone of ERAS because ERAS believes maintaining the physiological homeostasis throughout the surgery in the perioperative period will enhance the recovery. So a preoperative nutrition education to the patient. So the day the patient is scheduled for the surgery, inception of ERAS should be done at that time. Educate the patient, give him a choice for ERAS so that he can lead a different pathway of ERAS throughout his perioperative period. As I said earlier, ERAS is not limited to just carbohydrate loading. It will begin with preoperative nutrition and care from the prehab, and it will extend to the rehab. So the patient is discharged, and post-discharge also, the ERAS pathway will be continued. To understand how this works, let us quickly go through something what is called as a metabolic conditioning. So to understand this concept better, whenever there is an injury, any kind of tissue injury, for example, we will be talking about skin incision or infection or hypoxemia, hypovolemia, dehydration. All these injuries ultimately act upon the hypothalamo-pituitary axis, adrenal axis. So it will cause catabolism in the muscles. There will be protein catabolism, which will cause glycolysis. The axis will stimulate the liver to undergo glycogenolysis. There will be gluconeogenesis. So ultimately, there is going to be rise in the glucose levels, hyperglycemia, leading to insulin resistance. So nitrogen imbalance and insulin resistance is going to happen come what may during the perioperative period because surgical incision is imperative. So whenever this stress response of hyperglycemia and insulin resistance occurs, there is going to be pain, there is going to be ileus, there is going to be respiratory complications, and all these together are going to delay the recovery. So if you have to tackle the stress response, you have to tackle the insulin resistance, you have to maintain the nitrogen balance. And retrospectively, if you see this path, you have to maintain the perioperative nutrition. So adequate fluid intake, carbohydrate load, avoiding the excessive fasting periods, and early refeeding in the post-operative period, all this will lead to enhanced recovery. They will decrease the complication rates. They will not allow the protein catabolism happen at a faster extent. They will decrease the length of the stay. Because the patient will be fed early post-operatively, and not starving for a longer period of time, the comfort will be more and recovery will be enhanced. If I go on telling this, you will not believe me because this is a dogma in our minds and evidence is needed for you to release this dogma. So, having said that, there have been innumerable papers, original research articles, clinical trials which support ERAS. And there is this one table which I have taken up from a clinical trial where there are several recommendations and they have graded this recommendation. So, whatever we have till now discussed about the elements of ERAS, if you see all the elements, right from the counseling, smoking cessation, abstinence from alcohol, no bowel preparation, fasting, carbohydrate, and no pre-medication have a very strong evidence. Rehabilitation is still under study, and there is something called as immunonutrition, which is done for patients posted for oncosurgery. There is a weak evidence. Otherwise, all the other factors or the elements have a very, very strong evidence to be followed. In fact, this is a concept which was introduced in Scotland as sip till send, which means that the patient should continue drinking at least clear fluid till he gets a call to be sent to the theater. So this could be any clear fluid, water or clear apple juice, electrolyte solution. It could even be black coffee or tea without milk. It could be ice. So the patient can sip in 200 ml of fluid every hour till he gets a call to be sent to the theater. And this has been found to have very, very good outcomes as far as ERAS is concerned. Coming to the main thing as to implementation, how do we implement all these factors in our practice? Now, of course, we have to overcome many challenges that will come. First of all, we have to overcome our own traditional concepts. Anesthetists will have to overcome the dogma of the NBMRs. Surgeons will have to overcome their teaching of mechanical bowel preparation, without which they will not touch the patient for surgery. So all these teachings and attitude toward perioperative care that we have been following, that has to overcome. And then a vigorous training is required of the staff. So the team members will be anesthetists, surgeons, the nursing staff, occupational therapist, physiotherapist, nutritionist, dietitian, all these will form a team and start working on the ERAS. And only when all the members are on the same page and motivated to carry out this protocol can ERAS be perfectly instituted. First of all, we should understand the benefits of ERAS and convince others that these are the benefits of ERAS so that the hospital and the patient can both embrace ERAS equivocally. So what are the benefits of ERAS? So the obvious benefits are less complication, less readmission rate. It will reduce the length of the hospital stay, making it more economical. But the bottom line of ERAS and the benefit stays that the patient should be the one who should be benefited the most. Now, if there is a rich patient who doesn't care about the hospital charges and he wants to stay in the super deluxe room for say 6 to 8 days, so the length of the hospital stay is immaterial to him. Will you not follow ERAS in that patient? So obviously that is not the case. So how will ERAS benefit the patient the most? So this is a graph which is so self-explanatory. If you see a traditional protocol versus the ERAS protocol, they have compared the functional status. So in the traditional protocol, the patient has this pre-existing functional status. In the pre-operative period, there is no intervention. The patient comes for the surgery, undergoes the surgery, and naturally because of the surgery and the associated stress, there is fall in the status. Afterwards, during the surgery and the recovery period, it takes a longer time for the patient to be discharged and longer time for him to reach the pre-existing functional status. This is what happens in the traditional protocol. If you compare the same with the ERAS protocol, so if you see in the pre-operative area, we are going to intervene, we are going to improve the functional status of the patient by providing adequate pre-operative nutrition and optimization so that when he comes for the surgery, he is in a better functional status. Of course, there is going to be a fall in the functional status during the intraoperative period, but then in the ERAS protocol, you are going to intervene with the maneuvers, which will decrease the stress response and decrease the fall in the functional status. Also, because of ERAS, there is going to be early recovery. So the patient will soon reach the pre-existing status early. And further, if you see, the status will improve and reach the optimum status also. So towards the end, after the discharge, the patient will have better functional status than what he had even before the surgery. So you have cured and healed the patient because of the ERAS protocol. So if for the same patient, if you were to, the patient that we discussed, if you were to follow the ERAS protocol, so at the day X, it is decided that the patient will undergo a surgery. You label the patient, for example, that this patient is going to undergo ERAS hysterectomy or ERAS lap cholecystectomy. All right. So that is decided and a consultation is made. So the patient is ought to follow that pathway of ERAS throughout his admission. So he undertakes the preoperative nutrition, the optimization call, and then on the day of surgery, he comes to the OT. He is followed the ERAS protocol, so there is no pre-medication given to this patient. You take care of the antibiotics, you take care of giving an opioid-free analgesia, you don't give any sedation, you give multimodal approach. Okay, you don't put unnecessary tubes to the patient, and the patient recovers very well and he is discharged early. After discharge, also the consultation will continue to take positive feedbacks from the patient, and if there are any loopholes, you will take them as an opportunity to overcome for better outcome in the next patient. So this will be a usual pathway that needs to be followed if one has to take the ERAS protocol. Such protocols can be customized as per the surgery. For example, the same protocol for glioma patients, so neurosurgery. Here, the prehabilitation will be very, very important. So you will optimize his lung function test as well. Intraoperatively, you will give multimodal analgesia in the form of scalp blocks. In addition, you will also give anti-epileptic drugs to improve the mental status post-operatively. So this way you can customize the ERAS protocol as per the patient and the surgical need. So to summarize my talk altogether, ERAS involves a paradigm shift of what we have been taught, but remember that it is patient-centric and for patients' own safety. ERAS aims to optimize the perioperative matrix. So the perioperative pain, the perioperative recovery is all optimized because of the ERAS. ERAS targets the patient's preoperative functional status so that the clinical outcome and patient satisfaction improves at the end. Of course, ERAS protocol is ideal to have a pathway, an embedded pathway in an institute so that it can be followed. For example, when I quoted that whenever the patient comes to the hospital and is scheduled for surgery, that patient can be labeled as an ERAS patient. And then he will follow an altogether different pathway, right from pre-op till post-operative. And this last sentence is my own, which is that ERAS is not an all or none phenomenon. If you do not want to give the carbohydrate load, it is fair enough. You can follow other elements of ERAS and still implement ERAS and have enhanced recovery. So it is not that all the elements should be followed. Rather, whatever is possible and feasible at your working place should be done for enhanced recovery. So now next time when the patient's relatives are wishing their patients a speedy recovery, you as an anesthetist ensure that the recovery is going to be an enhanced recovery. Thank you for your patient hearing. Thank you so much, Sams, for having me here again. I'll stop the sharing now.
Thank you, Poonam, for such an excellent, crisp, very crisp talk. And really, from prehab to rehab, let us now start optimizing and let us now start following ERA. So, thank you, Poonam.
Thank you, ma'am.
Are there any comments, chairpersons? Sunanda Gupta, madam.
Yeah, that was a really great presentation, Poonam. And I think what you said was very clear that it's a heterogeneous set of evidence-based interventions which are grouped together into the ERAS pathway. And we should be careful that it has to be customized according to the type of surgery. And that is so very important. Just one set of rules cannot apply to, all the types of surgery. And similarly, it's so very important that the protocols we put in for cesarean sections are much, much different, which Dr. Sunil is going to highlight now.
Good evening, all. My screen is visible?
Yes.
Yes.
Thank you, Sam, the members of organizing committee for giving me this privilege. And thank you, Sunanda Madam and Dr. Anita for the introduction that you have given, elaborate, need not have been elaborate. So next 30 minutes or so, I shall be talking about the enhanced recovery after surgery following cesarean sections. And nil conflict of interest. Why have we chosen this topic, or why Sam has chosen this topic? Obviously, safety is the theme of the Sam, and so also of most of the hospitals across the country or across the globe. Safety is the in thing, and importantly, part of safety also and is enhanced recovery after anesthesia as well as after surgery. Only if the anesthesia is good, the patient can be subjected to ERAS, is what our practice, our belief is. And this was a beautiful paper by Pino et al. That got published in 2024. And as Poonam has said rightly, it has significantly reduces rate of hospital stay. This was in obstetric patients, statistically significant. And so also the opioid consumption was statistically significant. Other advantages, which though not statistically significant, the readmission rate, maternal complications, surgical site infections, and emetic morbidity also were lower in this group of patients. I'll come back to this paper towards the end of my talk. Historically, yes, again, there'll be a little bit of overlap between what Poonam has said, because it's a topic which is more or less a recent onset and just about 20 years old topic. And this was his Dr. Henry Kellett is the father of ERAS surgery, professor of perioperative therapy in Scandinavian Copenhagen country. And he was the first person to uh, discuss about this. But when we look into ERAS, when you look into that, there are so many factors. Patient is one of the factor which is very important, of course, but importantly, the nursing team and the surgeon, they play a very, very prominent role, and so also the anesthesia team. The if the patient has comorbidities, then of course the medical team or treating physicians who stabilize or preoperatively optimize the conditions are also part of this ERAS team. And importantly, how the surgical preparation or procedure is performed right from the pre-op to intra-op, as Poonam has said rightly, mechanical ball preparation, so on and so forth, and the operating room environment. And this is where we play a prominent role. And pre and post-operative care, again, those anesthesiologist plays a prominent role in these areas. And we'll be discussing comprehensively about ERAS, rather IRAC today. So again, little bit of history again. ERAS, even though in 1990s, 94 was the first study, but 97 was the first paper published. And the society was established only in 2000 with the aim to reduce the incidence of postoperative ILDs and length of stay. This was the goal initially when they came up. And the clinical pathway that was adopted to accelerate the recovery after colonic resection was mainly to look into the aspect of reduce the ILDs, reduces emissions, reduce intraoperative and postoperative stay, and they are incorporated just few things like optimizing preoperative conditions, diseases, enhancing nutrition. This is what has been elaborated elaborately by Dr. Poonam. So this is one of the important aspect of strong pillar of ERAS is improving nutrition preoperatively, monitoring for alcohol abuse, cessation of smoking, reducing the surgical stress, preventing intraoperative hypothermia, unnecessary avoiding allogenic transfusions, pain management, PONV prophylaxis, and early refeeding to avoid ILS. So basically, this was the minimum criteria that was adopted earlier in Denmark when the study was implemented, and they found that the patient had fantastic recovery, and that's how the concept of fast track surgery came into work in 1997. And this paper was produced in 1999, and if you see, ERA study group was formed in 2001, and subsequently the guidelines and society was formed in 2005, and subsequently several research papers came, and Iraq is a concept that is new. It came into existence officially only in 2018. So what is the difference between enhanced recovery after surgery versus enhanced recovery after cesarean section? Basically, the value of enhanced recovery, we know in obstetrics, is little different when we talk about parturient, because obstetric population by and large is a young population, and they already have a reduced postoperative complication because of their less number of comorbidities. But of late, there has been a paradigm shift in the type of obstetric patient that we get, advanced maternal age, patients coming with comorbidities, patient coming with morbid obesities, patient coming with IVF and ICSI conception, and medical complications, advanced like a grown-up congenital heart disease. So the comorbidities in the mothers are increasing, and this is where Iraq comes apt in this subset of patients. Importantly, the mothers also are supposed to take care of neonate as soon as they are born, and if they have to feed the neonate, they expect a faster recovery. And when we talk about maternal bonding, again, maternal bonding and the feeding of neonate depends on multiple other factors. The gestational age of the at which the mother has delivered, and the preterm baby, whether the baby needs NICU care or not. So basically, the breastfeeding is what is an important part of Iraq in I mean Iraq in a pregnant patient. So you have to remember that. Other thing is the mother, the neonate, and the surgery and anesthesia. This is the interplay. Iraq is the interplay between mother and neonate, which is unlike in surgery, we don't see the newborn. Importantly, if the mother has multifetal pregnancy, it can be 2 or 3 babies that they have to nurture immediately after surgery. And we expect that the mother recovers faster from anesthesia and surgery so that the maternal bonding also is enhanced and the incidence of lactation failure also can be minimized. So the perioperative scheduled cesarean section specific enhanced recovery program should include intraoperative nausea and vomiting. This is very, very important. Unlike in conventional eras, we talk about PONV, but in pregnancy, because 95 to 99% of cesarean sections we do under regional anesthesia, intraoperative nausea and vomitings are also management also is very important, because we know that the usage of uterotonic agents, externalization of the uterus, suboptimal level of spinal anesthesia, all can induce emesis, and post-spinal hypotension also can induce emesis. So management and prevention of IONV, PONV is important. Of course, remaining all of the things are part of Iraq program. Similarly, opiate consumption. Fortunately, opiate consumption in pregnant patients is on the lower side compared to non-pregnant women. But importantly, satisfaction also is important aspect. So we all know that marked dissimilarities occur between the pregnant patients and non-pregnant patients, and we need to standardize the policy so that we can impart Iraq universally across our country or across the globe. And evidence-based guidelines has to be there for obstetric specialty as well. And I would say, when I say obstetrics, both the surgery as well as the anesthesia. So coming to Iraq pathway, there are again Poonam already has elaborated quite a lot. I'll be emphasizing along with the level of evidence. So there are 5 elements preoperatively, there are 9 elements intraoperatively, and there are 11 elements postoperatively. And of course, altogether there are 25 elements. And we know that Iraq, if you want to implement in true sincerity, it has to start with antepartum education. The mother has to be aware about it, and the pathway should begin around 10 to 20 weeks of gestation, so that mother also is adequately educated, because maternal education is of paramount importance. So coming to the preoperative elements, as I said, there are 5 preoperative elements. First and foremost is NPO. Conventionally, as again Poonam said rightly, NPO for 6 hours, NPO for 8 hours, or NPO after midnight. The section may be there the next day noon. She may be the 5th patient in the list. So we know that average duration of cesarean section will be about 1.5 hours, 30 minutes of OT cleaning, unless you have 2 theaters or 3 theaters simultaneously going on. But importantly, restrict the duration of fasting. And if you look at the level of evidence, the strength of evidence is class 2B. It's a consensus expert opinion level of evidence, but restrict the solids up to 6 to 8 hours before surgery. Mothers also can take clear liquids up to 2 hours before surgery. As a protocol, we don't give carbohydrate loading in our hospital, but we encourage them to take API or barley water or coconut water or Glucon-D, which are clear liquids in our hospital. Non-particulate liquid carbohydrate loading, even though they have mentioned as class 2B, as I said, we don't, we are not using it at Fernandez Hospital because we have our own laboring drink. Our nutrition team has prepared a special drink similar to Gatorade, which gives glucose and also maintains hydration, so that adequate calories that the mother requires during fasting period has been taken care of. So to prevent prolonged starvation and to prevent starvation ketosis. Having said that, if the mother is having GDM, then we just encourage them lemonade or happy lemonade without sugar is what we follow. So the protocol at our hospital: solids for 6 hours, semi-solids for 4 hours, and clear liquids up to 2 hours before scheduled cesarean section. And unscheduled section, we keep a window of at least 60 minutes upon delivery, and we give, of course, all the patients receive antacid prophylaxis. Patient education is very, very important. And this is where the participation of the patient, not only the patient, but the entire family is important, because the success depends on the subject. And unless the patient has been adequately educated about this, what they have to expect from surgery, what to expect from anesthesia, how to enhance bonding with the newborn, and encourage the maternal bonding. We do right on the OT table. We adjust the temperature in the theater so that the neonatal hypothermia doesn't occur, and this is very, very important. So patient education is very important to uh, enhance or implement this program. Again, the level of evidence is expert opinion. The goals of Iraq, again, counseling is very important. Lactation, of course, as I said, maternal bonding is of moderate level evidence. RCTs, there are many RCTs, and some of the meta-analysis is also there, that early bonding with the baby, even in mothers who are in ICU, we have seen that patient requiring mechanical ventilatory support. If you put the baby on the mother's breast, it enhances the weaning, and we have got multiple cases on this. Of course, no publication, but we have seen the lactation failure rate is quite high in sick parturient. So if you put the baby on the mother's breast, even while they're on HD, non-invasive ventilation, invasive ventilation, even otherwise sick mothers, the incidence of lactation failure is significantly less. And this is what is important. And we have lactation nurses in our hospital, so that especially current genre of mothers, they have not been taught by their grannies and by mothers how to take care of the babies. And this is where the lactation nurse role fits in, and you can enhance the maternal bonding by this mediator. The last element of preoperative is hemoglobin optimization. One of the very, very important aspect of Iraq pathway is minimizing aerogenic blood transfusion. And even the WHO guidelines, ECOG guidelines, RCOG guidelines, multiple guidelines, they say that no mother who has a booked mother should come with hemoglobin less than 11 grams for delivery, be it cesarean section or could be normal vaginal delivery. And patient blood management program is a very important element. So even mothers who have CKD, erythropoietin can be given. If the mother has any hemophilias, appropriate factors can be corrected so that you can minimize blood loss, because we know that aerogenic transfusions always reduces immunity, and the prone for infections and surgical site infections. So minimizing blood transfusion is very important, and hemoglobin optimization is very important. In fact, there are protocols and guidelines that if the mother is having iron deficiency anemia or B12 or even folic acid deficient anemia, correction should be done. And if the iron deficiency is high, then they can receive, or they should receive parenteral iron infusion therapy around 32 weeks or appropriate intervals. But have the patient with hemoglobin of at least 11 grams and above when they come for delivery. Coming to the intraoperative elements, prevention of post-spinal hypotension is very, very important. If you see the level of evidence is high, level A evidence, and this is very, very important. So we don't treat post-spinal hypotension in our hospital, or even the AOA guidelines, they emphasize that post-spinal hypotension should never be treated. It should be prevented. So the message that should go is, post-spinal hypotension should be prevented, should not be treated. We should not come to a stage where it needs treatment. So either with cohydration or either with prophylactic vasopressor. We know that cohydration doesn't help much, and it is a prophylactic vasopressor like phenylephrine, 100 micrograms as a infusion to be added in the drip when spinal is being administered, and this can minimize post-spinal hypertension. So the drug of choice is phenylephrine or norepinephrine infusion. Importantly, if you give ephedrine, again, ephedrine is little emetogenic. So phenylephrine supersedes in terms of reduced nausea and vomiting and better maintenance of cord blood gases or reduced fetal pH that we see with ephedrine. So phenylephrine is a drug of choice, and if you can give norepinephrine 5 to 10 mics, that also is possible. But importantly, norepinephrine, you need to give it as an infusion, and level of evidence is high quality evidence. As has been said by Dr. Poonam, again, regional anesthesia is the technique of choice. Fortunately, everybody is following. In fact, most of the cesarean sections across the country are predominantly done under regional anesthesia, spinal being the most common technique. We in our hospital use combined spinal epidurals or CSAs or graded epidurals, or sometimes if the mother is having coagulopathy where regional cannot be given, or morbid loop dysplasia with coagulopathy, we use enhanced recovery based general anesthesia technique. So regional anesthesia is the technique of choice for cesarean section, and level of evidence is high. Maintenance of normothermia. Again, this is a very, very important element, even though the level of evidence is category C, but the strength is class 1. And importantly, active warming devices have to be used. We always say that once the baby is out, the mother starts shivering, and they say post-delivery chill. And this has to be prevented. I would like to know from the audience who are listening today, how many of you have warming system, active warming system in your hospital? Please put in the chat box. And importantly, how many of you have warming cabinet? Because every OT has refrigerator, but warming cabinets are relatively cheaper. Just it costs about 4.5 lakhs, little expensive than refrigerator. But importantly, you can keep at least about 15 to 20 IV fluid bottles, blankets in the warming cabinet so that the mother receives warm fluids. If you don't have a fluid warmer, this can be used as warm fluids. And of course, if you can have a convection-based warming therapy, nothing like it. But importantly, you have to remember that when the mother is bleeding and there is any sort of hemorrhage on table, then normothermia prevention is very, very important, because we know that hypothermia leads to acidosis, acidosis leads to coagulopathy, and we don't want the mother to go into the triad when the mother has an unanticipated obstetric hemorrhage. So even otherwise, maintenance of normothermia is very important. Again, I must tell you that in my own hospital, we don't put temperature probe because the mother is awake. But yes, we always put a cutaneous probe in desired cases. But if the mother receives general anesthesia, because invariably these are the mothers where region is contraindicated and they have some sort of coagulopathy or some problem, and the duration of surgery is also is prolonged. So always put an oropharyngeal or nasopharyngeal probe, preferably oropharyngeal probe. So active warming devices are of paramount importance, and this is what I was talking about, the convection devices. Nowadays, in fact, we have had a discussion with the company, one of the national company who came up with bear hugger devices. Like bear hugger is again is a commercial name, but this was from one of the company. I don't want to name because the conflict of interest. But they gave us a bed blanket. Like they gave us a bed blanket, not the hemotham. Hemotham is costing close to about 4 lakh rupees. So this bed warmer is nothing like a thermal blanket that we use on the over the body. So you have a bed warmer, and you can put a conventional body warmer, and it comes with a hose, which a Y shape hose. So one of the Y limb goes to the blanket that is there on the patient's back, and one of the other Y end goes to the patient on the patient's body. So the patient is warmed from behind, patient is warmed from above, and the temperature doesn't drop even by single degree. Very, very beautiful warming device. I've told him, gave him the idea and made him manufacture his Y-shape hose so that both the back as well as the front can be warmed, and you can minimize hypothermia. It's very, very important. The third important intraoperative element is appropriate use of utotonics. We know that again, IRAS and Iraq, this is one of the major thing which differs from IRAS. So in Iraq, utotonic administration, because we know that most of the utotonics, they cause emesis, they induce emesis. and the mother sometimes can retch, and which is a very, very unsatisfactory, or rather, the patient, the sensation is, the patient, sometimes they are not very comfortable with when they have the sensation of puking repeatedly, especially when they're using carboprost or when you're using methyl ergometrin, which we don't use routinely. And whatever protocol you have, oxytocin, generally in our hospital, we use low dose oxytocin as an infusion. Generally, 1 unit is given as or 1 minute, and subsequently 3 units is given over 30 seconds. And we start infusion around 10 to 15 minutes per hour for about 3 to 4 hours. If you're using carbidocin, we give either intravenous or intramuscular over 5 minutes. And in case of hemorrhage, you need to escalate as per your protocol. But again, level of evidence is very high. So do not give more when less is needed. By nature, the moment the baby is delivered, uterus retracts and contracts. What we are the reason of using uterotonic agent, oxytocin, is it enhances this retraction and contraction. And there have been multiple studies, many studies, where they have said that even 0.5 to 1 unit of oxytocin is enough to occupy all the oxytocin receptors of the uterus cavity. So whatever you're giving more, you're going to induce more of systemic side effects like tachycardia, maternal hypotension, and hypotension again is associated with nausea and vomiting. So use less when more is not needed. Why use more? Just less is enough. So oxytocin, be judicious with your uterotonic agents. And this is the technique, drug of choice. Carbitocin we don't use routinely in our hospital, but yes, some of the obstetricians are very particular of using carbitocin, but I have not found any added advantage of using carbitocin over oxytocin. Antibiotic prophylaxis again is a very high class evidence. Initially, we all know about 2 decades ago, we used to give antibiotic after the cord clamping, thinking that this antibiotic may traverse the cord and can induce antibiotic resistance in the newborn, which was again not well supported by the evidence. So the current evidence, I would say, it's not current, it's almost about more than 1.5 decade old. Give antibiotic at least half an hour before surgery, so that when the skin incision is made, the peak antibiotic concentration is there in the plasma, and you can minimize bacteremia that is associated with incision. Importantly, always prepare the skin with 10% povidone iodine, not 5% or 7%, or chlorhexidine 2% with povidone alcohol, isopropyl alcohol 70% alcohol. So we know that the bactericidal action of chlorhexidine supersedes that of betadine. Betadine, the bacteriostatic action on the skin stays for about half an hour, whereas with chlorhexidine, with isopropyl alcohol, the bactericidal action lasts for almost about 2.5 to 3 hours following application. So, bactericidal, chlorhexidine with isopropyl alcohol is what is preferred, along with antibiotic half an hour before incision is what is recommended, and you can minimize surgical site infection. This is what the peak concentration has to reach before the skin incision is made. And as a part of this, surgical safety checklist is of paramount importance that should be universally followed, because most of the things in the surgical safety checklist are checked. And another important thing is NPO, antacid prophylaxis, and antibiotics. This is what I was talking about. So if at all you are using povidone iodine, always make it 10%. And otherwise, you can club both chlorhexidine, povidone iodine applied, leave it for 5 minutes. There is no point in applying iodine and then immediately cleansing with chlorhexidine. Just leave it, allow it to dry, and then subsequently you can put chlorhexidine iodine. The fifth element is prevention of intraoperative nausea and vomiting. And again, we follow multimodal technique of prevention of nausea and vomiting. We use at least 2 different classes of antiemetic agents, either H2 blocker, like ranitidine, or PP1 inhibitor, along with H2 block is not an antiemetic, but it reduces the gastric acidity, gastric pH, and also reduces the incidence of emesis by reducing the acidity. But importantly, ondansetron with dexamethasone or metoclopramide with dexamethasone is what is important, along with PPI, which is given as a pre-medication, PPI or H2 blocker, whatever you are giving. But generally, we use perinom preoperatively, and intraoperative we use dexamethasone as well as with ondansetron, or you can repeat metoclopramide again. Again, paucity, or I would say the side effects of metoclopramide are relatively more, especially when they get extrapyramidal symptoms. So ondansetron again is a drug of choice in our hospital. Again, if you look at the level of evidence, it is mostly limited data category C. So emetic, the recommendations are prophylactic IV emetics of different mechanism of action so that you can minimize intraoperative and postoperative nausea and vomiting. Multimodal analgesia should be initiated from the time of spinal. And in our hospital, it is universal protocol to give intrathecal morphine. We give about 100 mg of intrathecal morphine along with bupivacaine and fentanyl. And if the mother who has a laboring mother with labor epidural coming for cesarean section, we give 3 milligrams of epidural morphine to this mother, and when mothers are followed up. Again, believe me, with 100 mg of intrathecal fentanyl and 2 to 3 milligrams of epidural morphine, the incidence of respiratory depression is virtually nil, non-existent. Having said that, mothers are still monitored because we know that one of the remote possibility of respiratory depression following neuraxial opioid, because the morphine is hydrophilic in nature, and the hydrophilic coefficient or lipophilic coefficient of morphine is just 5. That means the moment the morphine is given intrathecally, it does not bind to the neuraxial tissue, and it can ascend up, and by the time it can reach midbrain and reach the midbrain centers and may suppress respiration. But doses of 100 megs, hardly we see anything we have not seen. In fact, the naloxone which we have kept in our hospital last 27 years, we have never used it. We have used naloxone only for pruritus, never for respiratory depression. Having said that, you need to have this backup the moment you are giving neuraxial opioids. NSAIDs are again excellent choice for analgesia, multimodal analgesia. If there are no contraindications, ketorolac or diclofenac, aqueous diclofenac can be given along with paracetamol. So again, multimodal. You give ketorolac, you give paracetamol, you give intrathecal morphine. Most of the time, it works wonderfully. If ketorolac is contraindicated, or if paracetamol high dose is contraindicated, like you see in mothers with liver failure, then you need to go for sensory blocks like QL blocks or TAB blocks. Again, the level of evidence of multiple analgesia is level A. So the number of blocks, you can give multiple blocks like TAB block, erectospinal block, or quadratus lumborum block. We use PCEAs and PIBs regularly in our hospital. Mothers are very, very satisfied. Again, a very high level of evidence of using PIB blocks in parturients for, of course, laboring parturients, but we use for post-op analgesia also. And you can also give a specific block, ilioinguinal block, iliohypocristic nerve block. But again, by and large, TAB block suffices. Another problem that we have used or we have seen in TAB block is the variable duration of action. We used ropivacaine with dexamethasone. Initially, we have used clonidine also, but we found that clonidine gets absorbed systemically and mothers were little sedated. So we stopped using clonidine. We are using dexamethasone. And we found the TAB block, even with dexa, the duration of action varies from 8 hours to some of the patients, it goes on for about 15, 16 hours, but major of the time, it acts only for about 10 hours. Again, because you are required to give about 20 ml on each side, you need to remember that if the mother has received epidural dosage of lignocaine and then you are giving ropivacaine, so you need to remember that last can happen. So you need to keep that in mind that there is a cap on that. That way, erectospinal block uses less volume. QL block also uses less volume. Paracervical block, pudendal nerve block, we don't give. Generally, the obstetricians they give, but most of pudendal nerve block, paracervical block are banned in our hospital because sometimes antepartum movement, paracervical block can enter the fetal scalp and can cause fetal bradycardia. So we don't use paracervical block in our hospital. Pudendal nerve blocks are given only when they want episiotomies. Otherwise, oral intravenous analgesics and continuous wound infiltration is equally important. Again, a word about in continuous in catheters, wound catheters. Multi-orifice catheters have come in vogue and they have gone out of vogue also. Because if you are putting a multi-orifice catheter in the wound and subsequently you are giving infusion of analgesic, we know that the driving pressure from the syringe pump is about 300 millimeters of mercury, and the 300 millimeters of mercury, the drug escapes only through the proximal orifices. So only part of the surgical wound is covered or has pain-free, and remaining doesn't get any pain. So wound infiltration catheters, they are useless. We don't use it. We don't recommend it. Intrathecal morphine, of course, as I said, is a gold standard. NSAIDs are again gold standard, and promote breastfeeding. In fact, we are very finicky in our hospital about lactation because even the neonatologists are very keen that no mother should have lactation failure. And the skin-to-skin contact is established immediately after the baby is delivered by either normal delivery or by the cesarean section. So baby crawl is done immediately once the cord, a delayed cord clamping happens. When the cord is clamped, the baby is put on the mother's breast if the baby Apgar score is good. If the Apgar score is not that great, the baby is resuscitated, and once the Apgars are more than 7, the baby is brought to the theater, put on the mother's breast, and bonding is established. And in our hospital, the husband or the partner stays till the mother till the baby is put on the mother's breast. After that, the partner leaves the OT. IV fluid optimization, again, Poonam has mentioned adequately about IV fluids. Uh, there is a syndrome called SIIVT, syndrome of inappropriate intravenous fluid therapy. Should not happen. So excessive fluid is not good. Again, restrictive fluid. Also, you need to have a balance. So zero balance is what we also maintain routinely. So generally, in our hospital, we give about a liter to 1.5 liters of fluid perioperatively, and because they have a very short NPO. Again, I must tell you that NPO for 6 hours, I don't know why it came, when it came, but conventionally, because earlier we were giving general anesthesia using pancuronium. I go back to the I had era. In fact, when I joined postgraduate, we used to use flaxidil galamine, and then subsequently, when the patient was VIP, they used to use pancuronium, and then vecuronium, and then atricurium. So probably those were the days where NPO for 6 hours was needed because of the suppression of pharyngeal laryngeal reflexes. But current day, even if you're giving GA, if my patient is able to cough at the end of surgery, talk properly at the end of surgery, there is no pharyngeal laryngeal reflexes good, then there is no need to give NPO for 6 hours. It can be 10 minutes, 15 minutes. You can give liquids on the table also, because if at all there is no sense, you can she has enough strength to bring it out. So restrict fluids, start orals very early. In fact, before the Iraq came into policy, our average length of stay, I'm going back to 2006, 2007, when Iraq was non-existent and Iraq was just born. We used to discharge our patients at the end of 48 to 72 hours. I would say 48 hours if if the baby is fine, 72 hours if the baby needs prolonged NICU stay, or if the baby needs prolonged NICU stay, mother is discharged and comes on the OP basis to the NICU to feed the babies. So we followed this protocol right from 15 years onwards, but the concept of Iraq officially came very recently, 2020 is what I said. And this is what I was talking about earlier. Breastfeeding is very important, and it enhances weaning from mechanical ventilation, shortens the duration of weaning. So IV fluids should be reduced. You can just give ringalactate or normal saline, whatever your protocol is, but don't give over-infuse. Of late, we are following a balanced salt solution. Delayed umbilical clamping is something which is again everybody follows now, so that the neonatal hemoglobin increases by at least 1.5 to 2 grams if you clamp the cord after 60 seconds after birth. So that almost about 30 to 40 ml of blood is there in the cord. So you wait till the pulsations in the cord disappear. After that, the cord is milked, and then you clamp it. Again, the advantage is it enhances the iron stores, especially in preterm babies, and importantly, it has reduced the risk of necrosing enterocolitis and IVH also in the babies. And there is enough literature on the delayed cord clamping. I have seen in some of the obstetricians, especially a little older, the moment the baby is out, they try to put the clamp and deliver the placenta also. So wait for the cord pulsations to disappear and allow the placenta to separate on its own spontaneously. And that is where your uterotonic agent helps to retract and contract, and the placenta comes out. If you try to pull the placenta, you may sometimes end up with uterine inversion. So you need to keep that in mind. So coming to the post-operative elements, first and foremost is early oral intake. As I said, the conventional NPO of 6 hours should be banned. There is nothing like 6 hours NPO or 4 hours NPO or 12 hours NPO. NPO, is my patient able to cough? Is my patient conscious? Is my patient having adequate pharyngolaryngeal reflex? Start orals. Start orals. Start clear liquids to begin with. And then if the mother is already clear liquids, then start soft diet ASAP. But importantly, yes, if the mother has a risk of atonic PPH, history of atonic PPH in the past, then you can go slow because sometimes mothers may require like atonic PPH. The mother sometimes can bleed profusely and then can become drowsy. So elective cases, low risk marturients, don't wait for 6 hours. You can just start as soon as possible. And again, as Dr. Poonam said, ice chips can be put immediately. The IV line have to be kept for at least 24 hours. Don't remove IV line. If you're not giving fluid, doesn't mean that you can remove IV line. Leave the IV line at least for 24 hours and advance diet ASAP. So you don't have to wait for bowels to recover or bowel sounds to be heard. You can, once the mother is out of anesthesia, allow her to walk, allow her to do breathing exercises, need not be spirometry, but at least a little bit of breathing exercise like pranayama they can do. And we have seen that they recover very fast and also the satisfaction rate is high because the mothers, they walk early, they sit early, they eat early. The mental stigma that it's a major surgery, it comes out and they start recovering quite fast. Ice chips, it helps, but the level of evidence is again low. Early mobilization, again, not many randomized studies are there, the non-randomized studies are there, but again, what we have seen in our hospital is early mobilization helps. Early mobilization helps hugely, especially in obese parturients, especially in parturients who have multiple comorbidities, because they are prone for DVT. It reduces incidence of DVT also, and also enhances the diaphragmatic function, diaphragmatic excursion, and reduces the postoperative pulmonary complications. It is very important that the newly delivered mother gets adequate sleep because we know that quite a number of women, they suffer from lactation headache, postpartum headache, and one of the cause of postpartum headache is lactation headache because oxytocin sometimes can cause headache. So adequate rest and adequate sleep is very important. And adequate sleep, better to follow the circadian rhythm of sleep so that they get enough rest in the daytime, enough the activity in the daytime, and they get enough sleep in the nighttime. Rather than giving medicine to sleep, let them allow them to sleep naturally. Because many a times what we have seen is, especially mothers with induced labor, the induction, medicines are the prostaglandins are introduced sometime in the midnight, early hours. The sleep is disturbed, and subsequently after prolonged labor, they end up for cesarean section, and then so the sleep has been disturbed. So adequate sleep is very, very important for them to recover faster. This was a patient with a placenta percreta, received multiple transfusions, but you can see, despite being central and epidural catheters, she's been made to ambulate on the 0 day itself. And then this is very, very important. And importantly, when the mother has prone for pulmonary complications, start spirometry quite early. And this is again, breastfeeding should be done immediately. And as I said, make them sleep adequately in the night time, but beware of hypoxemic episodes, especially mothers who have severe preeclampsia or who have morbid obesity. They are prone for OSA, or they may be having OSA, and they become hypoxemic, especially when adjuvants or when medications to sleep are given. So refrain from using any anxiolytics to induce sleep, because we know that anxiolytics also induce or secreted in the breast milk, and they're not recommended. Early catheter removal is again one of the very important step of post-op elements. In our hospital, we don't remove at the end of 6 hours, but we remove at the end of 12 hours, most of the patients, most of the elective cases. But emergency cases, preeclampsia, other things we retain for at least 24 to 48 hours because they are on max self, and we need to monitor urine output. So at least for 20, till the max self is on, we don't remove the catheter. But importantly, mother is encouraged to walk with the catheter. That is very important. And importantly, post-catheter removal, especially there have been instances where the mothers have delivered vaginally or even cesarean section, sometimes multiple reasons, and one of the reason is intrathecal and neuraxial opioids. They go in for atonic bladder, or so you need to watch for that. Once the catheter is removed, you watch for bladder distension, and if the mother has not voided urine within 6 hours after bladder removal, you need to do an ultrasound of the abdomen and see that the bladder is not over distended. If the bladder is distended, then encourage them voiding. If at all she doesn't void in 8 hours, then you have to put a catheter, in and out catheter, and drain it. Otherwise, you may end up with retention overflow or sometimes atonic bladder. Again, it's very rare, but we have had few cases of that. Venous thromboembolism prophylaxis, again, class level A. Generally, we are very aggressive in following anti-DVT prophylaxis. Intraoperative by using mechanical thromboprophylaxis, either with TET stockings or SCD stockings, and postoperatively, SCD stockings are continued or TET stockings are continued. And along with that, you also use low molecular heparin therapy, especially in high-risk group. I have seen some of the hospitals, they use both TET stockings and over that put sequential compression stockings. This should be condemned, because we know that if you're putting sequential compression over TET, it induces DVT. So refrain from using TET and SCD both. Either use this or either you use TET stockings or elastic stockings, or use sequential compression device stockings. Do not use both. And if there is no contraindication, use pharmacological anti-DVT prophylaxis also. And again, for some reason, if the patient has bleeding and she doesn't require any transfusion, see that she gets correction of blood, correction of anemia before discharge. Very important. So she gets 1 to 1.5 grams or 2 grams of iron therapy before discharge, because some of the women, they come back with subsequent pregnancy with a short interconceptional period, and they come with anemia. So you need to do a CBC on the first POD or second POD, and if the hemoglobin is less than 9 grams, you can give them a shot of iron therapy as per the dose, as per the patient's weight, and see that the supplements are continued post-operative, post-delivery also. And again, WFSA, the patient blood management program has been taken very aggressively by WFSA. And one of the goal for 2025 is patient blood management program. No patient for surgery should come with hemoglobin less than 12 grams, either by uh, iron therapy or B12 corrections or fluid nutrition correction, or medical disorder correction. But see that the patient do not come with any anemia. So this is the goal taken up by WFSA. Also, we'll be hearing more from WFSA in 2025 about patient blood management programs. The next element is early discharge. Again, as I said, the discharge process in our hospital is about 48 hours following cesarean sections. High-risk patients, they stay for about 4 to 5 days, but otherwise low risk, 48 hours, they are discharged. Again, discharge depends on the neonatal condition also. But very importantly, you need to know that insurance patients, sometimes the discharge process takes 24 hours or sometimes minimum 6 to 8 hours. So you need to, again, this is where the administration comes into play, so that the discharge order, discharge is facilitated early and the administrative factors are corrected. It's very, very important. And use metrics to monitor the patient progress, and they go in for early discharge criteria. The discharge criteria is they should be pain-free, they should be nausea-free, they should not be in a surgical site infection, they should not have excessive bleeding, excessive lochia, and they should be able to express milk, they should be able to feed the baby regularly, and see that they are up and about. They are not dependent on nurse for their routine activity. So success during the postoperative pathway depends on depends on the elements that you have taken care of preoperative period, intraoperative period, and see that the postoperative elements are also followed, and the success of overall pre-op, intraop, and post-op, the patient can get discharged early. Limitations of drain, again, already has been mentioned by Dr. Poonam. As far as possible, do not put drains. In obstetric patients, we don't put drains by and large, Unless the patient is a case of percreta or accreta or coagulopathy, then definitely the mother has at least two drains, one subacute drain and one the tube drain. And the moment the function of drain is reduced, they remove the drain so that, and even with drains in situ, mothers have to be ambulated. It's very, very important. Again, need not have same post-op element. The breastfeeding support has to continue so that they don't develop lactation failure. You can minimize top-up feeds to the fetus. And this was the mother was septic shock. For some reason, if you are not able to establish maternal bonding, we have a video-based maternal bonding so that the mother gets oxytocin surge and you can minimize the lactation failure. So if the baby, especially certain mothers with sick mothers have sick babies, and sick mothers require obstetric critical care ICU admission, the sick babies require NICU admission, and both are not in a position to come together. And this is where the video-based counseling is very important so that they are in touch with the baby's progress via video counseling 3 times a day or sometimes more frequently. Multimodal analgesia, already I have mentioned about this. Again, the prospect guidelines for cesarean section, which came, I think this came out in 2022. Again, they encourage intrathecal opioid, they encourage NSAIDs, paracetamol, and local blocks, sensory block based analgesia, and the tab blocks, the QL blocks, all are recommended, whichever way you're comfortable. But see that they get good analgesia for the first 72 hours so that you can minimize long-term chronic pain and entrapment neuropathies also. Other things which are important are the glycemic control, promotion of bowel, return of bowel function. Again, hardly we use any opioids, so we don't have much of an issue. But glycemic control is very, very important, especially in sicker patients who require prolonged ICU care, so that the mothers, the poor glycemic control leads to higher chance of hospital-acquired infection. We all know that the better consult. So this was just a acronym for Iraq, all prawns clap to beat. So optimize comorbidities, limit fasting, delay cord clamping, prophylactic vasopressors. This is very, very important. Prophylactic vasopressors. So do not treat hypertension, prevent hypertension. Regional anesthesia, paracetamol, prevention of hypothermia, NCR, skin to skin contact, very important. Cleansing the skin, limit fluids, antibiotics, and so on and so forth. So ideal, as I said, uh, again, I said I'll come back to this paper. This was a beautiful paper by Pino et al., which got published in Obstetrics Gynecology Journal in 2024. Statistically significant reduction in hospital stay and opioid consumption. In fact, we have opioid stewardship policy in our hospital, like antibiotic stewardship policy. We have opioid stewardship policy so that predominantly the patients they get sensory based analgesia, reduction of opioids, and multiple papers where they have found a reduced length of stay. So to summarize, Iraq induces faster recovery, shorter stay, patients are more satisfied. This is very, very important. End of the day, bottom line, the metrics, patient satisfaction, and importantly, patients can return to work very quickly. So there are many, many guidelines. The guidelines have also added, from the surgical viewpoint, the blunt dissection of uterine hysterectomy for cesarean delivery, not to cut with the with the scalpel, and closure of hysterectomy in 2 layers, not four layers. There is no need to close peritoneum because there have been one school of thought with peritoneum closure is important to minimize adhesions, but there is not. So there is no need to close peritoneum. Women with more than 2 centimeters of fat, you can take a stitch in the fat with the catgut. And from the neonatal viewpoint, there is no need to routinely suck the neonatal airway for after birth. The babies have enough pharyngolaryngeal reflexes when they are crying. If the cry is vigorous, they can clear the secretions on their own. And routine neonatal supplementation, oxygen supplementation is not necessary. So to conclude, I would say that the 5 preoperative elements, the 11 post-op elements, I mean intra-op elements and post-op elements, they work very well. And as Poonam said rightly, you need not follow all 25 elements. You can follow at least some elements because to implement all 25 elements, it may be difficult. Start with at least, yeah, well, let me get closer to 20 elements and then start the program ASAP so that the patient's recovery is faster. So surgical rehabilitation is one of the things that I mentioned. Like we have a patient who is coming day after tomorrow with 188 kilo patient. So patients who come with multiple comorbidities, you need to start surgical rehabilitation, and we follow the new regime, the nutrition, endurance, and allaying anxiety, worry. W stands for worry. So when you put this patient on surgical rehabilitation, definitely the recovery is faster. Of late, I was discussing informally before the program started that we have moved from ERA to SERA and we have moved from ERAS to ERAS-E. The ERA is the concept of ERA was first published in Saudi Journal of Anesthesia in 2017, where they like ERAS they came out with enhanced recovery after anesthesia. So we came up with a concept during COVID, like when the list of surgical patients was reduced, we thought we should do something different for this patient, and we came up with why not complete recovery after anesthesia? So with the availability of rocuronium, Sugammadex, and sensory block, even with major abdominal surgery, we could get complete recovery after anesthesia. We could get the same skeletal strength. We measure the musculoskeletal strength with jammer. Jammer is a device which it's a hand grip dynamometry device which measures the musculoskeletal strength. So we measure the musculoskeletal strength before surgery, and we induce the patient with routine less opioid based anesthesia, no benzodiazepine, and predominantly good sensory blocks. At the end of recovery, once the mother is recovered or the patient is recovered after general anesthesia, we check the hand grip dynamometry, almost 95% of strength is reached, and they are fit to walk right from OT table. You make sure that they don't have postal syncope or they should not fall. So enhanced recovery after surgery to enhanced recovery after surgery from the point of extubation is what I mean. And with chloroprocaine, short-acting epidural analgesia, you can get a regression block very fast, and you can ambulate this patient quite early in the postoperative period. Importantly, most important, when you're in any protocol that you're introducing in your hospital, you need to have measures, you need to have metrics so that you know which are all the areas, the pre-op elements, intra-op elements, post-op elements, where adherence is not good from the surgeon side, from the anesthesiologist side, from the administrative side, or the admin factors. So all these factors should be analyzed and metrics to be presented in the hospital when all the departments, including administrative departments, are there, and that's how you can improve upon your goals. And these are the papers that I have referred before I presented this by making this presentation. And before I conclude my talk, two important announcements. I invite you all to AIG Hospital for the perioperative medicine conclave, the first of its kind in the country, in the 22nd and 23rd March. We have four interesting workshops: advanced focus, advanced airway, CPET, cardiopulmonary exercise. This basically this entire surgical rehabilitation, this workshop, and TCI, TIVA. The registrations are on, and I invite you to the 2025 AOA conference, which is being held at the AIMS Bhubaneswar. So registrations are on for both the conferences. With this, I conclude my talk. Again, I thank Sam for giving me this opportunity. Over to you. Thank you very much.
Thank you very much, Panda sir, for that excellent lecture and all the components of ERAS, covering all the components. I want Dr. Sunanda Gupta, madam, you want to comment? And
Yes.
Dr. Bhure, madam.
A really very good presentation and a very informative one. Now, implementing ERA's standardized care will likely be the most important change that you can all bring about in your practice, whether you work in an institute or you work in the periphery hospitals. And this will definitely improve maternal outcomes, improve the quality of care, help address discrimination in any form that can occur, and minimize opioid or analgesic dependence. But something important is that implementation of these protocols will need to place the patient's needs above that of the institutional needs. And I don't think the finance department is from a private institute is going to graciously accept discharging your patients within a day or within a couple of days. Yeah, very much. Now, these
In fact, but I'm sorry to interrupt you. What we have seen is by discharging the patient early, especially high volume centers, you get more patients. So a patient after third day ends up paying only room rent, but a new patient comes in, then they get the entire big package actually. So early discharges is now beneficial for most of the hospitals also.
Most of these guidelines which have been prepared are supported by SOAP, they have been supported by ACOG, they have all, and the IRAS Society, they have all come out with their own guidelines and they are specially made for the high income countries. So we need to set up our own guidelines which would take care of the situations, the resources which are available, especially, not high-end hospitals like Fernandez and AIG, but of course, district hospitals which are spread out in the nooks and corners of our country. And these guidelines should help all the anesthesiologists who are involved with for the mother and caring for these surgeries which Poonam talked about. And there are definite challenges in implementing these Iraq protocols. For example, structural and resource barriers are there. Then educating both the patient as well as the healthcare providers is equally important. And then battling with the staff shortages and inadequate availability of drugs and equipments. This will take a long time to, make Iraq protocols very safe for the mother. And especially when our rural mothers are discharged and they go off to places where, readmission or timely reconsult is probably very difficult. That is another issue, implementation of Iraq in our country.
So, madam, as you rightly said, yes, administration role and healthcare provider role becomes very, very important when you want to implement these protocols. But as I said rightly, there is a wholehearted support from the management to get these things. And once you put the advantages in terms of maternal satisfaction and the feedback that they give the mothers at the time of discharge, probably those are the things that the management, the hospital, healthcare provider can introspect and then they can implement. And it's, yes, coming to rural places where the manpower shortage, again, as I said, not every hospital they have lactation nurse, not every hospital they have enough staff to ambulate the patient right from within 2 hours after 3 hours after surgery, because you need adequate support to prevent
Warming devices,
accidental fall.
trying to
Followed
keep the patient with
by,
normotherapy. That's a big challenge in these
yeah,
places.
the big challenge. But I think what I have seen when even as a postgraduate, when I was doing my PG at Usmania Medical College in Hyderabad, there is enough staff. It's just that you need to have somebody to drive them to get the work done. And probably that is where a good administrator, the department administrator, the hospital administrator, using sometimes a whip if need be necessary, but put the systems in place and audit them. And once you put the advantages to the surgeons, even the hesitancy from the surgical side also can be reduced, because many times a sick patient who is on ventilator, the next day if they start walking or eating, the surgeons themselves are surprised. अरे कल ही तो ventilator पे था patient. So those kind of gestures and expressions, I think we need to put it across the surgical colleagues also, so that they also start involving early and preparation early. Because as I said, the patient comes to the surgeon first. And if we do the PAC a day before surgery or on the day of surgery, everything goes waste. Because if we are involved early, especially we deal with more of high risk cases, And when you're doing a high risk patient, I would be very happy to see the patient at least around 30 to 33 weeks of gestation, so that we have got at least full 6 to 8 weeks to prepare this patient, especially if they need surgical rehabilitation.
Very true.
Yeah.
Very true. And once the surgeons find out the immense benefits that Iraq has, nobody steps back, they are all ready to accept this.
I still remember we had a patient who was again BM of 160 plus, but thick pannus with fungal infection, cutaneous fungal infection. And the patient was scheduled for surgery depending on our comfort. As I said, see, you are going through, even though if you don't cut through the pannus, it's going to be a surgical site infection. So we prepared the patient for a week with chlorhexidine bath and other things, and she had a smooth sail. So if you don't give adequate time to remove those debris from the skin, especially when you have a panel which is like elephantoid skin at the lower part of the abdomen, the chance of infections are very high. So I think surgical rehabilitation should be done early, and importantly, if the anesthesiologist comes to picture early. So I think PAC should be done around 30 to 33 weeks so that you can stabilize them, correction of anemia or cross referrals, optimization, all those things can be planned, and mother is optimally prepared for surgery.
Yeah. Like even if you have an early discharge, the woman has to go to a remote rural location.
Absolutely.
Post rehabilitation centers near the primary treating centers are also in the pipelines. Yeah.
Can I join in, ma'am, in the
Yes.
conversation? Yeah,
Please.
the kind of patients, Sunil sir, we get. I also work in a private institute. So they remain in a very remote place. So contacting them and whatever. So the surgeons mostly are reluctant to accept this concept of IRAS. We've tried our level best, but they are very scared. And secondly, the occupancy. So for some reason, I think surgeons, it is difficult to convince them regarding IRAS. That becomes our problem.
So,
We
madam,
tried for even lap chole and all, but somehow surgeons are not very convinced. If you can advise us regarding that, it will be helpful to.
What we do is, madam, like surgical colleague, like see if we like the one of the reason for the surgeon to worry is if they come back with lochia or infection, what to do. So if you educate the patient, give them the alert signs, and as I said, we check for anemia before discharge, like fall in hemoglobin, and correct the hemoglobin so that they don't have to bother about, and give them the right nutrition advice. Importantly, you need to put one coordinator, even though they go far off places, the coordinator is continuously touch. And now with the mobile era, I'm sure every household has a mobile. So uh, yeah, every household can be mute.
Yes, sir.
So every household person, their brothers, they carry mobile and a video call, and they have smartphones also. We have seen people with even with low socioeconomic status, they carry smartphones. So a video-based chat call every 48 hours, they can follow up after discharge and pick up the alert signs if at all the mother requires. But yes, high risk mothers, definitely you can put extra thing, but otherwise low risk mothers, you don't have to keep beyond 48 to 72 hours, especially when there is no need to hospitalize them, because especially Dinanath Mangeshkar Hospital or any of those hospitals, they are all multi-specialty hospitals, and hospital-acquired infections are another threat to the mother, especially if you don't have stringent policies. Especially we have seen some of those corporate hospitals discharge them early from the ICU, HDUs to the ward so that you can minimize HAIs also. And having a coordinator who can follow up the patient post-discharge.
Yeah, and regular ANC visit also to the anesthesia OPD may be helpful, I think.
But here in our small hospital, the surgeons feel that their bed should be occupied. The bed should be occupied. They don't want their hospital remain empty, or most of the bed they want to occupied by the patients. So they don't give early discharge, or they don't allow us to implement these eras.
What other thing that we have seen is, sir, with the prolonged stay, you end up giving prolonged antibiotics also. Like we know that elective cases, low risk patients, just one stat dose of antibiotic which you give before skin incision should suffice. You don't have to give for 5 days of oral antibiotic. So by keeping the patient for extra days in hospital, you give them giving extra medications which may not be necessary, especially antibiotics and other things. But I think the presentation should be done in front of those surgeons, or give them the topic in the CMA so that they talk and they present and then they follow. So that's the only way.
I agree with Panda sir. Actually, I feel that all good surgeons will immediately understand the importance of ERAS. All good surgeons. But if the surgeons are like what Avinash is saying, they want their hospitals to be full. There are definite problems for keeping patients for longer, like hospital-acquired infections, which are very bad, and unnecessarily we should not keep the patient. But I think we should share these success stories, like what Pandesa was telling, that the patient on ventilator, next day she's eating and walking. So all these success stories should be presented in our clinical audit meetings. Like even in a small hospital nursing home, we are not taking suppose clinical audit meetings, but in our tea rooms we can share those stories with surgeons, that this enhanced recovery and the advantages of eras. So I think it all depends on how we are putting it.
Other thing that is very important is, madam, if you can educate the patient, when the patient demands, अरे मेरे sister को तो 2 दिन में रिचार्ज किया था वहां से, आप क्यों मेरे को 5 दिन रख रहे हो? If that type of treatment comes to the patient, empowering the patient is also very important. So आप 5 दिन तक क्यों रख रहे हो?
Bonding can be there in ANC visits only, sir.
Yeah.
For the book
Most
patient.
of the this
Correct.
happen. Patient's relative and patient are asking for the decision.
So as I said, the enhanced Iraq starts from 10 to 20 weeks of gestation, not at the time of
Very
delivery.
true. Sir,
Educate.
you were talking about the warming cabinets.
Yes.
So normally where this provision is not there, what is seen is in that syringe, this thing, the ringer and other fluids or bottles are kept, and
Yes.
it keeps on, it is placed there for more than half an hour or so, and the temperature, it really becomes hot. So would you like to advise something on that?
In fact, I said warming cabinet, in fact, most of the manufacturers are in Pune only. We got from Pune only.
But there the temperature is maintained.
37 degrees.
Yeah.
37 degrees. And that 37 degrees also is calibrated so that it doesn't become 42, because we don't want hot fluid going into the intravenous. That's very
Sometimes
important.
the fluid is very hot, and if we don't detect it, then it is going to be
We need
harmful.
to have a warming cabinet, which is a calibrated cabinet, calibrated by the biomedical team, and the temperature is continuously monitored outside. So externally, you can see that temperature at 37 degrees only, and uh, you can just give these fluids. Suppose if you have a fluid warmer, nothing like it, but not every hospital has fluid warmer. Somehow there is a hesitancy, but again, as I said, convection-based warming system every hospital should possess, because thermal blankets are very important, because each parturient may be prone for obstetric hemorrhage. We know that 70% of obstetric hemorrhage happen in unanticipated way, and we don't want to induce hypothermia in this subset of parturients. So warmers and warming cabinet have to be there in every hospital, I would say every nursing home. And as an anesthesiologist, we need to educate the hospital to insist that they have this warming cabinet.
You also mentioned about the Iraq pathway having 5 pre-op, 9 intra, and 11 post-op elements.
Yes.
So, one very important thing which both of you mentioned was, like Poonam said, that you start with whatever is possible. I think that can be a great beginning.
Yes, very important.
Because the problems are going to be at all levels, institution level, corporate level, and of course the private practitioner. So in the private setup, but the problems will be different. But this is encouraging that both of you said that with few elements you can go on, and then the improvement will automatically come to have a better patient outcome.
Even Sunanda madam said.
Madam, the surgeon's perspective that you were talking about, I think it is just a matter of time. IRAS is enhanced recovery after surgery. It is not after anesthesia. So it should be most of the surgeon's perspective. So much so that now in our institute, a surgery resident, a gynec resident, is doing her dissertation in ERAS. So time is changing, and sooner or later they are going to adapt ERAS because it is ultimately for them and the patient's benefit. So times are changing; they are getting more acclimatized to ERAS, and I was so happy to see a PG resident doing a dissertation on ERAS and incorporating us in that team.
We tried doing that in ortho, but they refused about 2 years back.
Ortho
My
generally they are
institute,
delayed responders, so
yeah,
later on, sooner or
Ma'am
later.
would
my
like to.
institute, the obstetricians gave a part of the thesis on Iraq, and she got the national award for it. So this
Oh,
was
so
2 years back. Yeah. So our gynae department was very, very happy with the Iraq protocols we started, and they still follow. All the units
I
follow.
think that's the best way, Sunanda madam. I think the giving a residency to the postgraduate and give them anesthesia topic also so that they know the benefits rather than only side effects of anesthesia. So I think that's the right way.
There are certain questions in the chat, uh, but I think it was already answered. Dr. Paliwal has asked whether any drugs or additives for spinal anesthetic that you give to cause less hemodynamic changes post spinal.
See, we generally, as I said, we give low dose bupivacaine, like 8 to 10 milligrams of bupivacaine with fentanyl and morphine intrathecal as a routine. And we use hyperbaric bupivacaine most of the time. We don't use isobaric.
And then the vasopressors we start early
So
on.
we start prophylaxis. They do not treat hypertension, prevent hypertension is what the AOA also suggests. We suggest and we follow the
So
same.
phenylephrine you give as a bolus IV. Now
We just we add in the infusion co-load 100 mgs so that by the time the mother gets spinal, the mother is turned supine with the wedge on the right hip and the things, phenylephrine goes in and you can minimize. And generally we give 50 bolus also, 50 bolus and 50 in the infusion, so that you can minimize or you can reduce or you can prevent post-spinal hypertension.
But sadly, mephentermine is still being used out there, which
Mephenterine was banned 20 years ago, madam.
but it should be strongly condemned. It is still being used, Sunil. In so many district hospitals, they still use mephenterine.
because this availability of phenylephrine is not there now. Neon has got that vial, so
Yes, 1 mg vial.
easy to actually
Yeah.
dilute and keep an infusion ready. So just load and inject, that is become more easy.
Yeah.
But still mephenterine, yes, I mean many of the peripheral civil hospitals they don't have ephedrine. So
What
they
we have seen is, madam, it causes very
It's
severe
mephenterine
increase in
only.
SVR. And if you see the incidence of post-spinal neurological emergencies, spontaneous ruptures of AVMs and bleeds have occurred because of massive, severe increase in systemic vascular resistance and uh, sustained hypertensive response. So we don't desire those things. So fentanyl should be banned. In fact, we stopped using almost 20 years ago.
But I said, no, you just find out from your district hospitals. They just
so
go
they
up.
don't have anything else, madam. So
But
they have
one more element that we have added, intraoperative, the 26th element, I forgot to mention is prevention of PDPH also. And as a routine, we should condemn use of Quinky needles. Always go for Whitaker needles, either 25 or 27. 27 is better. The incidence is less than 1%, but 29 is 0% incidence. And once you start using Whitaker, you fall in love with that needle, and it's a beautiful.
Is there any learning curve? Because Quinque is a sharp needle, so
I know. Yeah, actually, generally we have a hesitancy. This thing said one prick mein nahi hai spinal. I think every new technique or new needle or new device takes little time, but once you get used to it, it becomes very easy. It's just same as Quinky only. The introduce a needle and subsequently you just have to navigate it safely.
Is it required to
Ashok, what
aspirate
stopping?
when we are using Whitaker needle?
Sorry, say it again, sir.
We have to aspirate the CSF or when we
Generally,
are
sir,
using Whitaker needle for the confirmation?
no, say if you are using 29 gauge needle, it doesn't come out. It doesn't work. The aspiration doesn't work. So you just make sure that you are adequately inside the subarachnoid space, at least by 2 millimeters, more than 2 millimeters, so that the concavity hub is not in between the dura and the subarachnoid space. It should be completely inside.
Yeah, that's why
Uh,
I'm
and
asking.
stabilize it, and then you inject it slowly. Yeah. So there is no need to aspirate, sir. But if you're using 25, 27, then aspiration, you can get CSF. But with 29, you don't get aspirations.
Okay, thank you, sir.
But with 27, you can aspirate, sir.
You can aspirate with 27, yes.
Yeah.
But again, what I feel is the aspiration technique and other things, especially with Vitacare, the stability, unless you practice it, because it's a
Needle in needle.
it's needle in needle technique.
Mhm.
Sometimes the aspiration, if the needle moves out by a couple of millimeters, then you may get patchy. So better to have adequately put inside. You get the feel that you have punctured. That the beauty of Whittaker needle is you get a very good feel that you have punctured ligamentum flavum and dura. You get the dual click and dual pop. So once you get the pop, advance by another a couple of millimeters so that the entire concavity is inside the subarachnoid space, and then you inject slowly. So I don't generally aspirate when you're giving spinal.
Okay, there is one question related to surgical wound.
Yeah.
Question is there that we have many surgical wound infection in LSCS cases. So
Gaping.
what antibiotic?
Saying that there is gaping after LSCS.
That,
So what
that is
other
the
things than antibiotics and asepsis that we can practice?
Yeah, I think this
Yeah,
pop.
we have also one in our city. There are 12 cases in one hospital only. The
So
series of 12 cases.
the heart of infection control of any hospital is the CSSD department. So you need to relook at the CSSD policies, whether they are what level of indicator they're using, what is the sterilization method they are following. And so I think if the surgical site infection is more than 1.5%, then the hospital needs to introspect and look at the chain where the infections can occur, the poor skin prep. The antibiotic policy is just one of the element for preventing infection. There are so many things that are there: surgical asepsis, minimizing OT. How do you sterilize the OT? How do you sterilize the deep cleaning versus superficial? What cleaning you're using? What is the surveillance you're following in your OT? How frequently you do microbiological surveillance in your OT and ICUs, and how the wound is handled after surgery? So many things are there. I think the surgeon and the hospital should introspect all the cases, dissect them, and they can find the source. Sometimes we get the infection from the AC vent if the ducts are not properly cleaned, or the if you are not using microfilter HEPA filter which has not been changed for more than 6 months, it can shower bacteria through the surgical field. So you need to keep all those things in mind. Environmental factors, but more importantly, it is related to hand hygiene, sir. Poor hand hygiene is one of the single most important cause of wound infections.
But most of them are blaming to the surgical material, what they are using other than Johnson and Johnson or other
Suture material.
brand.
I think better to go in a non-biased way rather than putting one factor. I think honest introspection is what is important, what is necessary. So right from CSSD to the infection prevention chain, the infection control policies. So I think best to have an infection control officer who looks into all the practices from pre-op to intra-op to post-op. They review it, and then we look at the bacteria that have grown, where the hospital acquired bacteria or outside, common cells. So that also important. Suppose if the skin bacteria, then the skin preparation was like sometimes you see COMS, coagulation negative staph aureus. That means the asepsis, wound asepsis was suboptimal. Suppose if you see Pseudomonas or Klebsiella, that means they are acquired through hospital, through proper contamination or poor hand hygiene, poor surgical infection control policies. So it is just not mere antibiotic. There are many environmental factors and personal factors which are important. And many a times you have seen the theaters may they just wear the gown and come in. Most of the obstetricians and they keep wearing the surgical scrubs right from the OPD to the theater. I think that is another thing that has to be curbed, because surgical scrub is to be worn only in the theaters, not outside the theaters. So those policies are very, very important because many times we have seen busy surgeons, they go in and out of theater and they walk around the surgical scrub the entire hospital and they come and deliver the baby or they deliver the doses inside. Those things have to be curbed.
And remember those 5 cases of meningitis which occurred in
Absolutely.
a New
Dress,
York hospital just
dress,
because the anesthetist had a
Staph
severe
aureus infection.
URI, yeah, Staph aureus infection.
Dressner et al. In 2006, I still remember that journal. They
Yes,
grew
ma'am.
the same bug from the CSF and the patient surge anesthetist nose. So wearing masks is very, very important when you're giving regional anesthesia.
One question about walking on the day of surgery. Are you not afraid of PDPH? I think you have already answered this.
Absolutely not.
You
Absolutely
did.
not.
Yeah.
Yes.
So this is
Even
the entry point here.
we
Delayed ambulation is only going to delay the PDPH presentation. So there is no prophylactic bed rest to minimize PDPH. Allow the patient to ambulate.
Exactly. Your it will just delay the PDPH occurrence. Yes. Very good discussion. Any more questions? Anybody wants to unmute and ask? You can raise your hands.
Anita, this is Dr. Bande. Can I have one or two small comments?
Yes, sir.
Yes, sir.
Please.
Yeah. So regarding infection, I think as Sunil already said, it's more often subjects, maybe hand hygiene, poor maintenance of perioperative and even intraoperative contaminations. We did had these cases, and few of them were traced to CSSD, poor washing of instruments, etc. But I think all the antiseptic or anti-infection measures right from hand hygiene to CSSD, all are important. That has already been emphasized. We started IRAS in Noble Hospital where I'm working now, where surgeons were themselves instrumental in putting it, luckily. And I do not know in this group whether there are any of our anesthetists there. But it has been going on, and it was probably more effective since we had JCI accreditation achieved last year. So preparation started 2 years before that. So I think once there is a consensus, it is implementable. Small places, as Madam Bure said, or even I have worked in a peripheral hospitals many times. It may be a little difficult logistically due to occupancy and many other reasons. Regarding warming, the Sunil mentioned that cabinet which is manufactured in Pune. Actually, I was instrumental in making that manufacturer do that because 20 years back we were not having, and even now we don't have any option. But this cabinet is good. If those who want, I can give the contact later. But that's very effective, and it is automatically maintained 38, 39 fixed, and it remains. So we have one in emergency, one in OT, one in ICU, one in cardiac OT, I think. So it is always there, especially when emergency patients of hemorrhage in PPH or whatever other trauma. We give warm infusions, and that obviously starts treatment of hypothermia right in the beginning. I think all must have it. It's very cheap, not even very costly. So that is another indigenous products we all must have. And of course, we have so many warming other ways, hot air, bare type, or even mattresses are available. Coaxial warming hotline, which I wrote in this. So I think they are available, and this is one of the neglected. And Sunil did emphasize on this. This one particular aspect can be a contributor to killer, and where triad or quadrant of death is always been described when we learn about the lectures. So I think hypothermia, which is neglected, should be taken care of, and it is, I think, anesthesiologists who should take more interest, probably because surgeon may not be really that way interested in this one. Thank you so much.
Thank you, sir.
There one more question. Role of dexmedetomidine in ERAS.
Dexmedetomidine is an excellent alpha 2 agonist, and we use it routinely for general anesthesia, especially when we want to blunt the laryngosympathetic response. It's a fantastic drug, but now with the use of remifentanil, availability of remifentanil, dexmedetomidine is out. I would say we have almost stopped using it. But definitely to blunt the laryngosympathetic response at intubation, extubation, it's an excellent drug. Does not cause any neonatal respiratory depression. But having said that, with the availability of remifentanil, we have stopped using Dexmed in obstetric patients.
Poonam, can you guide on this? Poonam, are you
Yes,
there? Yeah.
yes.
Can you guide on this role of dexmedetomidine in other non-obstetric surgeries?
Yes, of course, you can use, madam. Like there are multiple analgesics other than opioids available. Now, of course, sir has described about remifentanil, and it is a wonderful drug because it is a short acting. So the long term effects that we are talking about, other opioids, which can be an obstacle to ERAS, are not there with remifentanil. But in other surgeries, when you want to use drugs other than opioids, you have magnesium that can be used, you have dexmedetomidine, a small dose of ketamine also can be used. So all these drugs need not be used in one patient altogether, of course. You have to tailor-made every drug to be used for a particular patient. For example, if patient is posted for TLH and I have to use a drug to as an adjuvant, opioid sparing adjuvant. If this patient is asthmatic, I will right away start her with magnesium infusion, add magnesium to the pile. So it will not only be a bronchodilator, it will have an opioid sparing effect. It will also ameliorate the hypertensive response associated with pneumoperitoneum. For spine surgery, I would prefer ketamine dose like 0.5 milligram per kg can be used. And dexmedetomidine can also be used for many such surgeries as an infusion form. So it has to be tailor-made for each and every case that you are going to use.
Yes, until we have remifentanil, because I mean, most of us we don't have access to remifentanil yet. So
Even
dexmedetomidine is a lifesaver.
lidocaine can also be used as a form of infusion for analgesia purposes. It also works well.
Yes.
Most of our
the patch, both all are available.
Yeah, but what about the cost for remifentanil?
Remifentanil at the moment it is quite expensive. I would say one milligram ampule or vial it costs almost close to 1,800 rupees.
No, 1 milligram is 900 rupees and 2 milligram is 650.
Probably I don't know. Which Themis, is it Themis?
Themis, yeah. Themis. It's in Maharashtra, local tax varies.
Yeah.
Thanks.
So probably, definitely, but remifentanil is a fantastic. 900, see, when propofol came into market, it was 600 rupees and thiophanate was 16 rupees. But over a period of time with the usage, the cost came down. So it's just a matter of time that the cost of remifentanil also will come down further. Same thing, dexmedetomidine also when it was launched,
Yeah,
it was
very
expensive. So now with the usage, it has come down. And even the, like say, remifentanil, if you can reduce it to, like see, not all patients require 1 milligram, especially for intraoperative use, unless you want to give it as infusion. So you can, they can come out with smaller doses also, like 0.5 milligrams and reduce the cost further. Because most of the patients, if you see the intubation dose is just 2 mg per kg and subsequently intraoperative maintenance, short surgeries, 1 or 2 hour surgeries, you don't require 1 milligram. You can just give, do away with 0.5 milligrams.
Okay.
Yes.
Most of our patient had vomiting after ketamine in small doses also. After giving all ondansetron and pantoprazole and so what is the reason? Even Dexa we are giving.
So basically, ketamine is one of the reason, or most of the anesthetic drugs can cause emesis, but surgical factors also equally important. So you need to look into different medications which are just ketamine alone or something else is responsible, especially if it is. You're talking about obstetric patients, sir?
All patients, not only obstetric.
OB, we don't use ketamine at all, unless you are inducing a shock patient, patient in shock. Otherwise, ketamine as such, low dose ketamine, hardly I've seen any emesis. Like what Poonam mentioned, we also saw sometimes upper abdominal surgeries where epidural is contraindicated. Routinely, we give fentanyl ketamine infusions. We don't see much of emesis, sir.
I don't think the PONV can be attributed to ketamine. One has to look out for other factors responsible for the nausea vomiting. I don't think it can be attributed to ketamine. Ketamine is not known to cause MSS.
Other reasons might be there,
Other
yes.
factors causing PONV.
I think Parna has raised hand.
Yes,
Yes,
Parna.
yes, sir. So, excellent presentation, and I'm sorry I missed on one point that you said that you use morphine and fentanyl in the intrathecal space, in neuraxial space simultaneously. So, like, what dose and how do you use it? So, epidurally you are putting morphine, you said.
No, so what we do is when we are loading bupivacaine, hyperbaric bupivacaine for spinal,
Okay.
the availability of morphine in our hospital is 10 mil, 1 ampere is 1 ml, 1 ml is 10 milligrams.
Yes,
So
sir.
we take 0.1 ml in a tuberculin syringe,
Yeah.
and that 0.1 ml is made 1 ml,
Yeah.
and
Yeah.
then we add 0.1 ml of that,
Okay.
and then add 0.4 ml of fentanyl.
Okay.
That is 20 max of fentanyl. So total volume is 2.5 ml. Otherwise, if you're using 80 mg bupivacaine, some of the fast surges, we don't have to use 10 milligram bupivacaine. Then you just 8 mg bupivacaine. Then it just becomes 2.2 ml, 2.3 ml. So with this, you look at the lipophilic coefficient of fentanyl is about 800. So the moment you give intrathecal bupivacaine with fentanyl, the bupivacaine and fentanyl, they fix to the neuraxial tissue almost instantaneously within 2 to 3 minutes. And of course, the complete binding happens in next 7 to 10 minutes or 18 minutes. And the lipophilic coefficient of morphine is just about 5 to 7. That means it will not bind to the lamina propria or lamina 5 or 6 lamina substantia gelatinous of the spinal cord, and it may hang around in the subarachnoid space and slowly can migrate or can ascend upwards. But it enhances the postoperative analgesia. The onset of action of morphine occurs after about 45 minutes to 1 hour, not immediately, but fentanyl acts immediately. So the duration of fentanyl is about 2 hours. Duration of bupivacaine is about 1.5 hours, and morphine almost close to 14 to 18 hours, to sometimes 20 hours also, the duration of analgesia. In fact, the duration of analgesia with morphine is superior to TAP block, superior to QL block, superior to ESP block, electrospinal block also. So if you can give intrathecal morphine, nothing like it. It's superior to any of those local blocks.
Sir, but the itching, the pruritus incidence is there?
Very, very less. With 100 micrograms is very less. If you exceed the dose more than 200 milligrams, then you see emesis and pruritus both. But with 100 micrograms, it's very insignificant.
I think
100 micrograms morphine and 20 mics of fentanyl, right?
And yeah,
Okay. Okay. And the same IV morphine you are using. We don't have diamorphine here, so the same IV morphine you are
yeah,
using. Yeah.
we don't have diamorphine.
Yeah. So same what we use for IV bolus, that same morphine you are
Same
using.
morphine, but it's a preservative free,
Yeah.
because there is one company in India that is not preservative free morphine.
Okay.
Make sure that whenever you are giving any neuraxial opioids and neuraxial local anesthetics, they should be free of any preservatives.
Okay. And so in literature, are there any articles about mixing two opioids for the final
Many articles are there.
fentanyl and morphine
Yes,
both are
yes,
there?
many.
Okay. Okay. Thank you so much, sir. Yeah.
Okay, Anita madam, it's almost 8:50.
Yes.
Yes, yes. This is time to
So,
I
conclude now.
request Dr. Rajesh to proceed with vote of thanks. Very excellent discussion. We have
Thank you.
Yes, it is always very interesting to listen Dr. Sunil Pandey sir and Dr. Poonam Ghoti ma'am. And the time is very short. So with this, we should, I think, conclude the session. Thank you all for joining us today for this insightful webinar on ERA. We would like to extend our heartfelt thanks to our esteemed speaker, Dr. Sunil Pandey sir and Dr. Poonam Ghoti ma'am, and for sharing their valuable insights with us. We also appreciate our chairpersons, Dr. Sunanda Gupta ma'am and Dr. Anjali Puri ma'am, for their expert comments on today's topic, that is ERA. Thank you, organizing members, for making the webinar a success. Dr. Anita Nete ma'am, President of SAMS, Dr. Avinash Chibose sir, President-elect of SAMS, and Dr. Parna Thakkam, the SAMS News Editor. A special thanks to all the SAMS members who have attended this webinar on ERAS and who took the time to join us today. Your participation and encouragement makes our webinar worthwhile. Thank you once again, and we look forward to your continued support in our future webinars also. Thank you all.
Thank you. Thank you very much, Sam. And
Thank
thank you, Madam Sunanda and Anjali, Madam.
So
Thank you.
Thank
you.
you.
Thank you
very
so
much.
much.
Thank you, all the
Thank
speakers.
you very
Thank you, Sam.
Happy Christmas.
Yeah, Merry
Then and Happy New Year.
Happy New Year to all.
Bye.
Yes, Merry Christmas and good night, everybody.
Good night.
Merry Christmas. Thank you so much.
Thank you.
Bye.
Bye, ma'am. Bye, everybody. Thank you.
Bye bye.